2. This is our presentation on progressive supranuclear and progressive pseudobulbar palsy. So origin of topic. Progressive supranuclear palsy is a rare brain disease that affects walking, balance, eye movements, and swallowing. This disease results from damaged cells in the areas of the brain that control body movement, coordination, and thinking. These areas of the brain include the brainstem, basal ganglia, cerebral cortex, and the cerebellum. These are all areas of the brain that control voluntary and involuntary movement, like previously mentioned. Unlike pseudobulbar palsy, this condition is considered a disease, and the cause of the disease is unknown. The only association that is made is that they are both caused by old age. Each of these conditions have similar symptoms, but PSP has more of an effect on the body's movement as a whole, while pseudobulbar palsy has more of an effect on facial muscles and facial function. Then we have pseudobulbar palsy. It is not a condition itself, but rather a complication of other neurological and cerebrovascular conditions. These are conditions that affect blood flow to the brain. They can include stroke, aneurysm, or brain bleed. The main features of pseudobulbar palsy are difficulty speaking, swallowing, and rapid dramatic mood changes. Symptoms can also include excessive drooling, weakness, weakness of the tongue or paralysis of the tongue, facial muscle weakness, outbursts of uncontrolled or inappropriate laughing or crying. Pseudobulbar palsy occurs when there is bilateral damage to the corticobulbar tract in the brain, which connects the cerebral cortex to the brainstem, and that also controls facial muscles. Certain other neurological diseases like MS, ALS, and stroke can lead to the damage of the corticobulbar tract, resulting in pseudobulbar palsy. The corticobulbar tract is a bundle of nerve fibers that originates in the primary motor cortex of the frontal lobe. This connects the cerebral cortex, which is the part of the brain that's responsible for voluntary movement, to the motor nuclei of the cranial nerves in the brainstem.
So the neuromuscular effect of progressive supranuclear palsy on the body is severe and occurs in 4 stages, generally spanning 5 to 9 years. In the early stage 1, the first year, symptoms are considered more mild and can sometimes be overlooked as typical problems of aging or misdiagnosed as Parkinson's disease. Initial balance issues and fall risk are observed at this stage, along with reduced motor control of the eyes and reduced speaking volume. Mood changes, including apathy, depression, and mood swings, are also common. Stage 2, years 2 to 3, the illness becomes more distinguishable and an accurate diagnosis is achieved. Significant balance problems are observed, with mobility aids often required. Patients will have speaking and swallowing difficulties, like slurred speech, and an increased choking risk. There is a decline in vision and motor control of the eyes, including voluntary or slow blinking and twitching of the eyelids, alongside increased mood changes. In stage 3, spanning years 3 to 6, cognitive issues worsen, including memory impairment. Significant mobility issues and muscle pain and stiffness result in wheelchair use. Patients have limited control of the tongue, mouth, and throat, and have difficulty speaking and swallowing. Vision impairment worsens, and choking and pneumonia risks are high. Affected individuals require comprehensive care for most, if not all, of their needs at this stage. Stage 4 is the final 3 to 6 weeks of life of this terminal illness. Patients are non-ambulatory and wheelchair bound. They have no motor control of the eyes, mouth, tongue, or throat muscles, resulting in rapid weight loss. Feeding tubes are common. Fall injury and infection are very dangerous. Patients have severe cognitive, bowel, and bladder impairment. Quality of life is the priority, shifting to palliative care for these patients. Pseudobulbar palsy is more centralized to the face, mouth, and throat compared to the more full body effects of progressive supranuclear palsy. The clinical constellation includes dysarthria and dysphonia, which is impaired chewing and swallowing, impaired mastication and dysphagia, glossoplegia and trismus, which is paralysis of the tongue and lockjaw, emotional lability, also called pseudobulbar effect, both related and unrelated to the patient's mood, is a common symptom. Exaggerated facial reflexes are also observed. In some patients with pseudobulbar palsy, seizures and cognitive impairment are observed, including in up to 85% of pediatric cases.
As for the testing, diagnosis, and treatment of progressive supranuclear palsy, diagnosis relies on clinical presentation of progressive weakness in the muscles that involve the mouth, throat, and losing ability to speak and swallow. Further testing may involve electromyography, EMG, to assess nerve function in the affected muscles. Currently, there is no treatment that can slow or stop the progression of PSP, but treatment is basically managing emotional lability using medications such as antidepressants, SSRIs, or TCAs. But there ultimately is no cure for this disease. As for pseudobulbar palsy, diagnosis relies on clinical evaluation through MRIs to identify the underlying brain lesion causing the upper motor neuron damage, while treatment focuses on managing the symptoms like dysphagia and emotional lability. Treatment follows supportive care like managing swallowing difficulties and speaking issues. As for therapy and rehab, progressive supranuclear palsy, as stated, is more of a full body effect. So some of the therapy includes physical therapy to manage pain, stiffness, and discomfort while improving balance and gait. Something they commonly learn is how to fall to minimize injury risk. Physiotherapy is also used with an exercise regimen that includes aerobic exercise, flexibility, motor cognition exercises, gait and balance training, visual tracking, and other intensive routines to help patients, especially older patients, balance and avoid falls as previously stated. Occupational therapy is used to help patients perform activities of daily living, while speech therapy is used to help improve speaking and swallowing. It also helps with facial expressions and for patients that have to use keyboards for talking. As for pseudobulbar palsy, therapy and rehab, speech language pathologists are used to help with difficulty swallowing and speaking, adjusting eating posture, using eating tools, training the muscles that help you swallow, and physiotherapy such as electrical, magnetic, or thermal can also be used for this purpose. Physical therapy helps patients to strengthen their tongue, lips, jaw muscles, and facial expressions. Whereas respiratory therapy can help patients to maintain and improve lung functions. But overall, for pseudobulbar palsy, the rehab and therapy is mostly to help with swallowing, improving lung function, and other facial injuries. Here are some of our references. And if you have any questions, we can answer them now. Thank you for listening.